एक्सपीरियंस सर्टिफिकेट दवा मैं जितनी पेशेंट का कुटुकटी
A very, very good afternoon to all of you on World Cerebral Palsy Day. I'm Dr. Asha Chipnis from Mumbai, India, welcoming you to Global Listening and Sharing Session. It is a joint effort of Indian Academy of Cerebral Palsy and International Alliance of Academics of Childhood Disability. Our greetings on World Cerebral Palsy Day. As we move through today, we have an esteemed panel who would be talking about functional thinking versus diagnostic thinking. By any chance, if people do not want to be recorded, follow this slide, keep your videos off, change your name, go ahead. Today, I feel our goal in this 1 hour session is to offer a global multidisciplinary view to identify the many dimensions of the issue regarding both the diagnosis and the approaches to services and enable people to see that their issues are almost always complementary to one another. With this, I request our President Mallikarjun sir to give few words. Sir, please unmute yourself. Sir, unmute yourself.
Good afternoon, all of you. On behalf of Indian Academy of Cerebral Palsy, we wish you a wonderful National and International Cerebral Palsy Day celebration. This 24 hours consecutive global listening and sharing session is a second in series. The first in series was organized in 2020. It was successfully. Many countries participated in the session. The global listening and sharing session main goal is to provide a platform for healthcare professionals to reflect on their experiences, innovations, challenges from working with the child with disabilities. This is a great opportunity for all of us and professionals to on this occasion to reflect our experiences collectively across the globe. Today, for this session, we have a wonderful, reputed professionals from different disciplines. We requested them to represent on behalf of Indian Academy of Cerebral Palsy. We express our heartfelt thanks to the faculty who given consent to be panelist on behalf of Indian Academy of Cerebral Palsy. Hope today we are going to have a great, wonderful feast, academic feast. I welcome all of you and thank you for joining, all of you for joining this session. And also I request you to give feedback using QR code shared with you. Thank you very much. And over to Asha.
Thank you, sir, for your kind words. I invite Dr. Jonas, who is the who represents the International Alliance, and also he works very closely with the Dutch community of disability. He could give a message to all of us here in India.
Good afternoon, everyone. First of all, happy World Cerebral Palsy Day. This is indeed, like Mallikarjun said, the second time that we're organizing this global event, which started this morning at 8:30 local time in Singapore, and will across the world, will travel the world in time zones in 19 sessions over 19 countries. We're ever so happy that India is joining us. It's going to be a wonderful session, I'm sure, and I wish you all the luck and all the best, and have a wonderful day today. That's practically all I have to say, to be honest. And over to you, Asha.
Thank you, Jonas, for your
Thank
kind words. We start our session now, and I'm going to introduce one of our top speakers of the day, none other than Professor Dr. S. Sitharaman, who is the Professor of Pediatric Medicine, in charge of Child Development Center. He was the General Representative for the PLMC Child Center at the SMS Medical College. He has many accolades, and he also has a WHO fellowship on Child Health 1991, Former Health Fellowship in Pediatric Neurology. So we welcome you. Please unmute and give your thoughts.
Okay. Unmuted?
Yes, sir.
Am I audible? Yeah.
Yes, sir.
Okay. Good afternoon to all of you, and good morning where the time zone is good morning, and good evening where the time zone is good evening. And I must wish you all a very happy World Cerebral Palsy Day, and it has been a wonderful day to in fact interact with all of you. And I must thank the Indian Academy of Cerebral Palsy for having invited me and sharing my thoughts on this process. Representing some of the issues from our development pediatrics point of view, we have in our country definitely a very significant proportion of children with disabilities. The earlier history, we had problems of quantifying the problem, and subsequently we have found that when the government of India took over, that during the national census, a disability can be actually be recorded in the national census. That the first attempt which was made to actually start identifying people with disabilities, and that pushed the cart towards recognizing the magnitude of the problem we have. And this has been a major issue in deciding how to relocate our resources for this issues with children with special needs. Fortunately, with the increasing awareness among the government sector as well as the political will, we have a lot more hopeful thing to see now. There have been certain deterrents and complicities also, and one of the major ones is the number of medical carers in our who and the therapists in relation to the number of children being affected. And it has been a uphill task trying to get all the children being registered, one, and also providing adequate number of therapists for the same. And unfortunately, the thought process in our general Indian population is to have one-stop solution to all their issues. When they meet a doctor or any therapist for the matter, they would want a solution to their problems immediately after they have met him. And it has been a very difficult task for us to organize them in a manner that they have to be sent to various therapists for that matter. And this issue has now been slightly being recognized, and we are able to impose upon the parents to recognize that a team effort is required to help their child. But still, we have a long way ahead, and I still feel that all the personnel who are dealing with these children would definitely should be, kind of integrated into all the aspects of the therapies. A pediatrician may know much about physical therapy or occupational therapy, something about speech, and same as the other ones, all the other parameters, other therapists also should be equally conversant with this, because that will somehow help us to tide over this situation. The Indian Academy of Pediatrics, fortunately, to bring about sensitization, has launched a flagship program of early childhood development, which is by 2023, we expect around 10,000 pediatricians to be sensitized to these issues regarding the child development, also the solutions to be provided for. And government has also looked into the issuance of medical insurance, and a very unique project of their where the Child Protection Services, what we call the RBSK program, has been able to identify many of the children at the ground level, at the village level, and starting from there. Because what was happening was, we were getting these children quite late when as a referral systems, because most of the therapists and most of the assessment centers were targeted on metros. Now there is an outreach system which brings about the children from the rural areas to the metros, to the hospitals, being identified at the government level. The second issue was, we still are now in the phase where we do not expect that the number of professionals handling these children would go in proportion to the population control, population increase sort of. So what we do now, so we are wanting what our centers now presently is trying to develop a community based approach, trying to ensure that if a person comes from a periphery, he need not stay around for the therapy for long. He is trained for some time and asked to be monitored regularly at local level or after 3 months to their centers, because it is physically impossible for the person from a rural area to visit a therapist more often. And this is the type of approach which, though it is simplified, I know it's compromised a little bit, but there is the solution to solve most of our children's problems. Otherwise, we would not be able to target them in totality. And there is definitely an approach of changing, creating awareness. The attitude is changing, and now even the professionals who are working at the periphery are getting sensitized to these issues. We are still trying to maintain a certain degree of focus on issues where therapy is concerned, and since it's a comprehensive management has to be carried out, this particular approach which has been adopted by our center is actually helping us to sort of target all the children and give them some degree of satisfactory replies. And with that, I hope that this model in coming 2 years would be successful enough to address most of the children who are coming from the peripheral areas. And I wish you all a very good, very happy World Cerebral Palsy Day, and we're happy to share anyone who has got these kind of experiences, which who can share with us, so that we can be more fine-tuning our approach toward these issues. Thank you so much.
Thank you, sir, for your thoughts.
Yeah.
Now I invite our second speaker for the day, none other than Dr. Shefali Gulati. She needs no introduction to the Bombay Institute of Medical Sciences. She's the Chief of Child Neurology Division. She has many papers, many accolades to herself and prestigious awards. I welcome you, Shefali, to give your thoughts. I'll allow you to share the screen.
Thank you, Asha. Greetings to everybody. Depending on the time zone, good morning, good afternoon, and good evening. And I thank the Indian Cerebral Palsy Association to have given this opportunity to share. Just give you some thoughts of mine, having been working in this field for last 25 years. Just few things is that we have to understand, between the title today was functional versus diagnostic thinking is very important. And Shane E. Bryan had said that he had a problem in writing because of dystonia. He didn't look at it as a disability. He thought it was a challenge. So he could overcome that challenge. How could you outsmart that challenge? So that is how positively we have to take, and he ultimately wrote books on that. We as clinicians, as pediatric neurologists, pediatricians, doctors have to look beyond the medical model. We have to look at the capability approach, look at the barriers in participation. Disability, when you have impairments, activity limitations, participation restrictions. But what I want you to know is that disability is the interaction between individuals with a health condition like cerebral palsy, today we are talking about, and personal and environmental factors. And the second part is very important because they are the negative attitudes, the inaccessible transport, inaccessible entry to the public buildings, and limited social support. All of them are very easily modifiable in the system. So that is very important to be seen as. And this is a very important, another point is it's very common. And we have to prevent an impairment from becoming a disability and handicap. And there are 3 levels of prevention. Primary prevention is from preventing something to occur. Secondary is early diagnosis and early institution of intervention, which is very important for all professionals, including doctors and all other allied professionals. And tertiary is rehabilitation, and there's a lot of technological advances in all that. And research is going on to understand the modifiable risk factors and the genetic causes and all, which comes as CP mimics. That is something different, but we have to identify them early. We have to ensure that these children are included in the school and ultimately in society. And now the smaller children, sicker children are surviving because of improved neonatal and otherwise pediatric care. So that is why this is becoming very important. There is a paradigm shift and we have to all focus, and that is why it's a public health importance. And we have to keep in mind that when seeing the child, we have to see total environment, because poverty, poor stimulating environment at home, malnutrition of the mother as well as the child, and other diseases are going to add on to the ultimate achievement of the developmental potential of the child. And we had this study which we had done with INCLIN, in which I was a network coordinator of this project, in which we found that 12% of children in the age group of 2 to 9 years had one or more neurodevelopmental disorders, out of which CP was one of them. And next, one important thing I want to flag is 1/5 of them had more than one condition. That means they are coexistence of comorbidities. And in that year, when we saw, when this was a data collected in 2011, and that year we had the census. So from that, we extrapolated and found that CP children were around 3.1 million in the age group of 2 to 9 years. So if you extrapolate to across lifespan, you look at account the numbers of persons we have to see. I think the need of the hour is to understand the primary, secondary, tertiary prevention, early identification, and correct and early institution of management with associated comorbidities, and have some social culture sensitive tools and empowerment of professionals as well as parents. Primary prevention, we know classically of the neural tube defects is there, but there are all research going on, and we have to diagnose them early, and it is important. So we have screening tools developed, which are NDST and ASQ, which are socio-culturally sensitive tools we have to have for screening these conditions. We have diagnostic tools available. This neurodevelopment screening tool is now being used in Rashtriya Bal Swasthya Karyakram, is 2 to 9 years. Then we also have this less than 2 years screening tool to identify and screen for these conditions. They have to be used more so that they're good psychometric properties. Then you have neuromotor impairment tools, which include CP. Then you have the autism tool, you have the ADHD tool, you have the epilepsy tool. Why you need to know is 1/5 of them are going to be having comorbidities. And all these tools, actually, the original INCLIN tools are screening, as well as the other ones are being used in the Rashtriya Bal Swasthya Karyakram. And we had also taken out a document which in which it was suggested by the Ministry of Health that there should be a worker at the district level, which is going to help break the maze for the families. The families should not be lost between various ministries, because we have 4 ministries catering to children with special needs. There's the Ministry of Health, you have the WCD, you have the HRD, as well as Social Justice Empowerment. So you should have somebody at the district level. All these tools have been converted to mobile apps or easy use by point of care clinicians. And we have to understand that not only the diagnostic part, we have to integrate the diagnostic and the functional component for the child. It is very important. And the entire treatment is multidisciplinary. We have to keep in mind and know all the team should work together, because there is one child. They should not be in silos. I feel most of the problem in India is because they go to various therapists and all, they're working in silos. So you should have all of them coordinated, and although even if not working under the same roof, they should be connected. And we have to also empower the parents. We have to provide the information material for parents as well as professionals. And that's what I wanted to know. They have to be told in their regional languages. That is very important. And we have to go towards technology also. I want to understand that there is technology going on. We have teleneurology, which is there, which will help these people, because they cannot take absenteeism from the schools, and the parents cannot keep taking. You have to keep in mind that rehabilitation is not the old times. We have new virtual reality things coming up for CP. You have artificial intelligence based for diagnostic and mobility devices, transcranial magnetic stimulation. All these are being used in CP, compression garments, cooling scarves, various devices and all. And something important is augmentative alternative communication and all. So all these we have to keep in mind and move forward. Right now, there is nothing in stem cells. That's what. And just wanted last line is that Annie McDonald has said not being able to speak is not the same that nothing there is to say. And challenge is to make every differently able child not only count but also capable. And we should remember, when the world says give up, hope whispers try one more time. Thank you so much. So basically, early identification to, having empowerment of the professionals and the parents, and the use of upcoming technology. Thank you.
Thank you, Shefali, for your thoughtful words. If you can start. Yeah. now I invite Dr. Atul Bhaskar, who's a pediatric orthopedic surgeon from Mumbai, and he's had his stints in Toronto. He has many accolades. Welcome, Dr. Atul. I will stop sharing and you can go ahead and share.
Yes, thank you for your kind words. Can you see my screen?
Not yet. Now we can. Yeah, we can. Just make, yeah, go ahead.
Thank you very much for the invitation. And, conventional thinking has always been that orthopedic surgeons usually use a hammer and a saw. But I think this is one condition where the decision is more important than the incision. And I think I'm grateful that Dr. Shefal has given such staggering figures. But besides the population of disability, one must remember that 45% of these children, of these patients are also illiterate. And that's why they fall prey to a lot of these unconventional therapies, and they keep jumping from doctor to doctor, or from from quacks to people who don't understand the disorder. So that's the real challenges we face in our own practice. Now, all of us know the approach to a child with delayed milestones. We know they need a thorough examination, they need a thorough history, appropriate imaging at the right time, EEG, and if the MRI is normal, you think of genetic causes, you think of metabolic causes, and something like children's stroke, which can be prevented. So these may be of academic or research interest, but one must not miss a treatable condition, because that will be the biggest injustice to a child who's got a treatable condition where we can intervene with the help of our colleagues. Imaging are really going to see change, and now we can do specific MRI scans, we can do MR spectroscopy, PET scans, and really classify the subtypes of CP. But this may not be available everywhere, and I think even in our country, getting a basic MRI done, in a rural center is next to impossible. So I think this kind of imaging access must be made available, so at least we can have some correlation between the type of brain lesion and what we can expect. The new concept which is evolving over time is the concept of neuroplasticity and neural networks. So really, we must question whether brain lesion is static or there is ongoing neural repair. I think there is a lot of happening now in neuroplasticity about using manual therapy, constraint-induced motion, and there's a great work from Dr. Yona from the Cerebral Palsy Alliance that there is a complex interaction between genetic factors, experience, either behavioral or pharmacological, that differs across the lifespan of a child. So I think this is where the role of our allied specialties come in, with the therapists and specialized adaptive aids. Orthopedic surgery usually is a tertiary kind of field where we always come in when the diagnosis is more or less established and the brain lesion is stable. So unless the child has been through all this, neurologist, pediatrician, we can offer very little unless the actual pathology is not controlled. So if they've got epilepsy, that must be under control. They must be seeing a therapist already before we start doing any kind of surgery. And we know that surgery can be effective in certain children. We know when to do the operation. Usually the first 4 or 5 years are spent in diagnosis, and that's why we don't try and intervene with surgery very early. It's only around the 7 to 10 years of age where we start doing single event surgery. So where we know we can make a difference to the child and the GMFCS scale is more or less stable. We have simple scores to assess ambulatory potential. So we look at the child's ability to stand, what about his cognition, his motor control in the upper limb, and then only we base our decisions. We also have the GMFCS scale, the functional motor scale, and a gait lab now to assess which child will benefit. So every child may not need surgery, but there are other options available as well to improve the mobility versus ambulation. And we know what types of deformities are seen in these children. There are enough papers in literature to know which subtype can cause which problem in the child. And this is because of the muscle contractures which are progressive and also because of lack of rehabilitation. So we know what happens when these children are untreated. There is progressive increase in contractures, there is gait impairment, and most importantly, energy expenditure. These children cannot walk just because they don't have enough energy. They just use a lot of oxygen and they get very, very tired. In non-ambulatory children, hip dislocation is very common, almost 70 to 80%. So every child who is non-ambulatory grade GMFCS 4 and 5 must be screened for hip dislocation or hip migration. And we also did a survey in 2006, looking at the hip abduction angle. So any combined abduction angle less than 45, one must initiate a hip X-ray to prevent or diagnose hip dislocation very early so that they don't need major surgeries. Surgeries are not done for certain children where we feel that there's a lot of cognitive issues, dystonic CP, significant sensory disturbances. And here we rely on other aspects of treatment. It's not only ambulation, but one can think of seating, palliative care, specialized devices. As Dr. Shefali has mentioned, there are a lot of things happening now where we can, improve the function of a child. The main problem is cost and accessibility. And this is what we find in our own practice. The initial years of a child are spent in diagnosis. And then when they come during adolescence, there are several challenges. This we see, because I work both in private as well as the public hospital. There are a lot of issues regarding the mental and physical issues, social isolation, logistics, rehab. So they may come for some time for rehab and then they'll just give up. So these are real challenges. And this is also found even in countries like UK, where the transition from youth to adulthood is very, very poorly coordinated. So many of these children, when they become adult, we really don't see them. We really don't know what happens to them during adulthood. So hence, I think we should look at ambulation in CP from a different context. This was my colleague from Toronto, Dr. Uni Narayan, who has done a lot of work in this field. And I think we should look at bodily impairment, limitation of activity, restriction of participation, and think about the overall child rather than just focus on ambulation. And our parents do not counsel this at the outset, and they seek untested treatments like stem cells, hyperbaric therapy. And when they come to us, they really exhausted all their means, and they are quite disgruntled that nothing has happened to this child. So one must think of the child as a whole and look at all the factors if it's practical. And there is this very good paper from Gillette Children's Hospital where we still don't know what the real outcome can be used. So objective assessment has always been a problem in measuring outcome in CP. And although we have multiple tools available now, tools for assessing energy, functional assessment questionnaire, but there is a gap between technical outcome and the functional outcome. And this is where I think our colleagues can help us by developing new apps. So not to forget that we need a more practical and a more human approach, not to get overwhelmed by diagnostic jargon. They may have multiple genetic tests, multiple MRI scans, but one must not get bogged down. Have maybe a practical app-based score for every child, maybe the future. And you must keep the child and family in the loop about the treatment, unless we get lost and we start Googling for treatment everywhere. So I hope in the future, we can achieve this vision, which is the main vision of the government of India. Try and have accessible India campaign. Every child must have access to services, healthcare services, which can improve his or her function. Thank you very much.
Thank you, Atul, for your kind words. And I agree that family needs to be kept. If you can stop sharing.
Thank you.
Thank you, Atul. Really, thank you. Family is the core. Now I invite Dr. Koili Singh Gupta, who's a developmental pediatrician. She's basically works at the Umi Child Development Center. She's a senior consultant at the SRCC Narayana Children's Hospital, Mumbai. She's a member secretariat board at the International Developmental Pediatric Association and the International Society of Autism Research. She's a resource committee for the Forum of Autism, a visiting faculty at the TISS Mumbai, leads ECHO Autism and WHO CST Mumbai. She's a trainer at multiple parent professional workshops and publications, has many publications in national and international journals. Welcome, Koili. Thank you for coming. Do you want me to share your slides?
I'll share them. In case it doesn't work, then I'll ask you to share.
Go ahead. So I'm going to
Well, thank you so much, Asha, for your kind words, and a big thank you to the association for having me here, and a big thank you to all the people who are listening in. So I'm going to just share this. Asha, will you please let me know if it's visible?
Yes, absolutely. You are fine.
Okay. Okay. Thank you so much. So today this is about, a diagnostic versus a functional thinking. And that's what I want to focus on. So I just remember this a 15-year-old boy whose parents came to see me from a smaller town in India about 2 years ago. And this was the second or third time that they were coming. This child had a GMFCS level of about 3 and had been going to 9th standard at that time. And they said, when will my son start walking? And I felt, okay, we've been over this question over and over again, and it seems not so possible that he's going to walk independently. But what I did ask is, can you please tell me about what is your hope? What do you hope that this, will be able to achieve when he starts walking? And the parent and the son, they looked at each other and they said, my son wants to go in for science, and the science classes are conducted on the 3rd floor, and he'll never be able to make it to that if he's not able to walk, because the building did not have a lift and there were stairs that he would not have been able to climb. And there it was, the key importance of that functioning at some point transcends and goes beyond diagnosis, right? The diagnosis wasn't changing, but what was changing for this young person's life were the functional needs. So yes, very often we might, say that Indian parents are focused on fixing. And in fact, there has been a lovely study that looked at qualitative reports from Indian versus Canadian parents and by Jindal et al. In 2018. And their findings did show that Indian parents were more focused on fixing body structure and function challenges and, looking at independent walking as compared to the Canadian cohort. But they also found that Indian parents spoke about the difficulties with social and cultural beliefs that get in the way, that there is lack of access to services and inaccessible communities that make them think that, the solution to the problem is when the child starts walking, right? And colleagues of mine at Umeed, led by Dr. Rupa Srinivasan, who adapted the participation and environmental measure for children and youth, the PEMC, they translated into Hindi and adapted the work. And when they looked at participation of Indian children with disabilities, they found that they had significantly lower rates of frequency and involvement in activities across home, school, and community settings. And no wonder that caregivers are really interested in greater participation and involvement of their children across multiple environments. Now, interestingly, while the GMFCS does a great job of being able to predict so many things, what is also shown in Indian studies is that one thing, if you look at this, I don't know if you can see my cursor. So here they looked at the lifestyle assessment score in this study from South India. So I'm trying to focus only on Indian studies today. So if you see this, you will see that the GMFCS had a strong correlation with physical independence, mobility, clinical burden, schooling, but it did not have a correlation with social integration. And that's interesting because another study similarly picked up similar things, that the GMFCS is not really very good at predicting how integrated the child will be overall in society and in activities that are, meaningful to him. And if you see this here, you will see that what predicted quality of life in Indian children, once again, are very interesting things. Social well-being and acceptance is the first thing, functioning of the child, participation and physical health, which brings this point to us very clearly that as therapists and professionals who are working with individuals with cerebral palsy and other disabilities and their families who are living with this disability, focus on functioning is paramount. Now, the core deficit, so motor deficits in cerebral palsy, core deficits like social communication and autism, it's not all. When we are working with disabilities, we need to understand and remember that the disability and the experience of disability goes way beyond the core deficit. So for instance, in cerebral palsy, there can be many documented difficulties, right? We know that there may be epilepsy, seizures, there will be developmental impairments like cognitive impairment, impairment in speech and communication, along with academic difficulties. But unfortunately, there are often those difficulties that go undocumented, uncharted, unaddressed. Most individuals with disabilities face bullying and significant amount of social isolation in the settings they are. They have lesser number of friends, their relationships are not as powerful and as meaningful as many other children, and that it impacts their self-esteem and their quality of mental health. And of course, many of them may have comorbidities, psychological and psychiatric comorbidities, anything from anxiety disorders to mood disorders, which often go unaddressed. And it's important that when we, as my predecessors, Dr. Bhaskar and Dr. Gulati spoke about seeing the child holistically, the whole child, we need to keep in mind that when we are talking about functioning, the child's anxiety, his, self-esteem or lack of it, academic difficulties play a very important role in lowering his level of functioning and need to be addressed as much as we need to address the physical disability or the physical comorbid piece of it. The other piece, in this interesting study from Kerala, where the researchers looked at the quality of life with children with cerebral palsy once again, what they found is that parental well-being is a significant determinant of quality of life, right? And we can understand why this is so, because societal attitudes, the stigma surrounding disability, and of course, environmental barriers, while they can be easily fixed, they don't. Some of you who live in Mumbai may have heard about this group of people who tried to make a footpath disability friendly, wheelchair friendly, and the next day it was overtaken by street hawkers, right? It didn't take 24 hours for things to go back to where they were. So these are real, these impact quality of life. And if we want to work on functioning, and if we want to address quality of life for children, we need to remember that family-centered care is a very important thing. And to support functioning of children, we need to equally support functioning of parents and their well-being. So in summary, individuals living with disabilities and their families, they are living the experience of disability, and therefore functioning and addressing functioning is paramount. While the diagnosis, I'm not asking for a binary approach. Yes, diagnosis helps us direct intervention. Where do we start? What do we focus on? But functioning of the child and family has to provide us the direction. Addressing core deficits, it's not enough. We need to address comorbidities, and the family's functioning and well-being is equally vital. So much appreciation today for listening in and being part of this session. Thank you so much.
Thank you, Koili. I agree that direction, diagnosis, I agree that diagnosis is direction and function is that. Very, very well said. Now I introduce one of our great therapists, Dr. Raju Parashar, who has his doctorate from Teachers College of Columbia University. He works at the Venkateshwara Hospital, New Delhi. He has several academic positions. He's the director of Amarjyoti Institute of Physiotherapy, University of Delhi. But I think so for all therapists listening in, he's been mentored to me and many others. Welcome, sir. Thank you for joining.
Thank you, Asha. And should I share my screen at the moment?
Yes, sir, please.
Okay, I hope you can see this at the...
Yes, sir. Absolutely. Just make it full screen. Yeah, absolutely, sir.
Okay. So thank you very much. I'm really appreciative of this for this invitation. And thank you, Asha, for initiating this invitation. I really appreciate it. So let me first thank the Indian Academy of Cerebral Palsy and the International Alliance of Academies of Childhood Disability for this invitation. This is an excellent subject that is current and topical. I come to this conversation as a physiotherapy clinician primarily, though my background includes academia and research, as Asha has already mentioned. All of these are not mutually exclusive, and they are interrelated. I've worked in 3 continents, so I come with that experience. And I also should mention that my specialization is motor control and motor learning. And you'll see why as my presentation goes forward. So this conversation about diagnosis versus function is taking place across a number of disciplines and geographies in healthcare. And I think that the impetus to this discussion, I think, is due to a shift from an exclusively medical model to a biopsychosocial model of healthcare. And more importantly, patient-centric focus. So as a lot of my colleagues earlier have mentioned, the earlier presenters, and my job becomes a little easier because they've touched upon most of the items that I would like to touch upon. The patient comes to you primarily and says, when can I sit, when can I walk, etc., etc. So function is the fundamental goal or the primary goal of all our patients in the realm of disability, but also otherwise in healthcare. So historically, we've seen that physical therapists have been talking about PT diagnosis or physical therapy diagnosis. Originally, it was proposed by Shirley Sharman in the 80s and 90s. She proposed a movement-based diagnosis. And recently, actually, it has been re-established by the Academy of Neurological Physical Therapists, which is also movement task force based. But interestingly, even the psychiatrists have been talking about the lack of or the inadequacies of diagnosis. And recently, an editorial in Dialogues in Clinical Sciences asked the question, the need for the diagnosis, and asked the question, is a syndrome or a collection of symptoms enough? And I guess that's what we do in cerebral palsy as well. Nursing, by the way, has been doing this. They're the most progressive, and they've been doing this, and the most well-developed, actually. And they've been having this conversation since the 70s. And I'll end with that. In fact, a lot of clinicians over the years, particularly physical therapists, and I don't know, maybe pediatricians and neonatologists and etc., have also been asking the question, do we create discipline-specific diagnosis to better serve the patient? And I expand upon that right in this area of disability. So very quickly, what is a diagnosis? It's a label encompassing a cluster of signs and symptoms that are associated with disorder, syndrome, impairment in body structures, dysfunction. And I'm sure all of you all are seeing a linkage between the ICF model and our old NAGI model as well. What is the purpose of a diagnosis? And again, I don't have to stress on it because a lot of you all know about it, but just as a re-establishment of it, it's a guide to the clinician in determining the most appropriate assessment and intervention strategy. Mind you, function, keep in mind, function is the ultimate goal. But to get to that goal, we have to do some things in between. So traditionally, diagnoses have been linked to mostly to, because it came from a medical model, it was linked to the pathophysiology of the disorder. And in other disciplines of medicine, say gastroenterology, etc., it continues to be that, and it is important. But in the area of disability, where there's a huge team that looks after the patient, we have gone beyond just pathophysiology. Currently, the problem that I find, and I mean, I'm willing to listen to others things, is that all disciplines who are related to the to disability or the rehabilitation of children with disability or people with disability, is that we use the same parameters and thus arrive at the same pathophysiological diagnosis or conclusion. However, this does not serve the primary purpose that I laid out earlier, that it's not giving us any direction as to how to intervene, or there is no discipline-specific intervention. So interestingly, what we have, through conversations with colleagues, etc., each discipline implicitly or explicitly creates a discipline-specific problem list. And physical therapists or physiotherapists have been doing this for years. And I know this because right from the 80s, we've been trying to do it. So each discipline should, I suggest that each discipline should evaluate their own set of parameters at an impairment level, which then can guide their intervention to achieve improvement in function. Remember, the goal is function. And even my previous speaker spoke about function and the others as well. So a pediatrician, a neonatologist, a psychologist, a physiotherapist, an occupational therapist should each examine different parameters that are mutually exclusive so that they arrive at a discipline-specific diagnosis. However, it is also important that these diagnoses should be linked, as the final outcome is common. All of us are working towards improving function and reducing disability. So this is just a rehash of what has already been spoken about and what originally used to be the NAGI model or the ICF model. And so we have to link pathophysiology to impairment, to function, and then to disability. The impairment level becomes discipline specific, while the functioning is common goal within the context of the biopsychosocial model. So this is just a rehash, and I'm going to go over it. Let's look at some of the problems with the pathophysiology. This pathophysiological damage results in impairment, dysfunction, and disability. Unfortunately, it's static. It needs to be dynamic as the damage is distributed. And I think Dr. Atul was the one who mentioned that our brain or the cortex is constantly reorganizing as we have stimuli from the outside, as well as the internal damage that has already taken place. However, it gives us some information, or albeit minimal, that what kind of strategies we can apply. So example, types of exercise using upper motor neuron, lower motor neuron, ALS, etc. So it's relatively more beneficial in the early stages. Now, let me shift a focus to function, as everybody has spoken of function.
Half a minute, sir.
Half a minute. Oh, okay. So let me very quickly say then that function is a challenge. What is the challenge to function? We have a person who is working as the body as the performer or the patient, and then we have a environment that we are working in. And the interaction between the two gives us 14 functional items or functions that we need to deal with as the clinician. And if you go from left to right, you will see that we can start at a very low level, standing, sitting, etc., but then also moving in space, running or crossing a street, which becomes. So we have to address all these functional items. Half a minute. Okay. So finally, just let me say this, that, there has to be both. We have to have a diagnosis for each of the disciplines, and they have to be discipline specific, which should be, I think, at an impairment level. These should be linked to a function, which is the final goal. And if we need a template to do this, nursing has done a great job. They have 13 nursing domains with 47 classes and 4 types of nursing diagnosis. So thank you very much. I appreciate it. I don't know if that is 7 minutes, but thank you in any case. Appreciate it.
Thank you, sir. Thank you so much. Now, I say if you can stop sharing.
Yeah.
Now I invite Dr. Sita Desai, psychologist and special education, founding director of HT. Do you want me to share the slides or you're not going to?
Yes, Asha, I would appreciate it if you can share the slides, please.
I will share it. Sorry. One second. A minute.
Do you want me to do that?
Yeah, that would be good.
Yeah, you want me to share it? Okay.
I'll stop sharing.
Okay, sure. Give me a second.
Yeah, it's good.
Is this visible, Asha?
Absolutely. Go ahead.
All right. Okay. So I just need to get rid of this. Okay. So yes. So first of all, thank you everyone for being here, and Asha, thank you for inviting me. Dr. Mallikarjun, thank you for inviting me. I think what I'm going to do is, wrap up all the, what all the speakers had to say. There were some wonderful presentations. I think I myself have learned a lot. And there was a lot of very, very related information that came from the just previous presentation by Dr. Raju, where he spoke about the diagnosis, the functional approach, as well as the biopsychosocial approach. I think these are all very much a part of my presentation, but in a different way. So the way I thought I would kind of wrap up, all the different aspects that have come about diagnosis and functional approaches is to take a psychological perspective on it and a slight shift in terms of how I'm going to do it, because I'm going to share my experiences with families as well as with other professionals on how we have worked using both the diagnosis and the functional approaches. So my way of looking at it is, I have a 4-point agenda today, and that is, to look at what are the diagnostic and functional approaches, and basically what are the implications on the different stakeholders, and then seeing, how would an integrated approach work rather than just taking any one of them. And of course, what are the challenges and the opportunities of using this integrated approach, with the final focus being the child or the individual, family empowerment, and community engagement. So the way I'm looking at it is that, yes, we go through the diagnostic processes, or we're using the functional approach in order to arrive at a better understanding, as well as serving the child and the family. But what happens, and which we, which I think Dr. Coyle spoke about, that there are a lot of other undocumented facts. And that is, we're not, I don't know where we're documenting the emotions of the people who are engaged in these processes, and how these emotions are then leading to behaviors which can be either useful or not very useful to what is going to happen to them next, right? So this is, this is how I am just approaching today's presentation to you, because what has been happening is, across the last, almost 3 decades, the organization that I head, Drishti, we have been engaged in a lot of assessments and therapies. And what we have done across at least a couple of decades is that we have been documenting how people, what are people's emotions like when they complete a process, okay, whether it is therapy or it is assessment. And so we actually get them to mark out, their emotions, like how are you feeling right now? Okay, at the end of a diagnostic assessment, at the end of, a comprehensive assessment, or at the end of, say, an entire 3 or 6 months of therapy, right? And this is what I want to present to you. So one is, of course, what are some of the benefits and the limitations of using a diagnostic approach? And here I'm saying psychodiagnostic because I'm talking about, a psychodiagnostic approach, which is using different diagnostic tools, which many of you may be familiar with, like an IQ test or some academic achievement tests or personality tests. And then we're also talking about, the more academic tools that are used for children with special education needs. So we might be using, like I said, achievement tests, or we might be using, school data. So we've got different data points that we will be collecting. And of course, some of the benefits of a psychodiagnostic approach largely is that parents and even the older adolescents, the young adults, seem to understand the outcomes in a very tangible way. They also get to know what is, the prognosis, and they tend to get more educated about what their expectations should be, so they get more realistic, and also what might be the resources available, right? And then, like for everything, whether it is a diagnostic approach or whether it's a functional approach, there are limitations, right? So what families also find is that there is quite a focus on the deficits, right? We aren't talking so much about strengths. And so what we have been doing since a number of years in our diagnostic reports is that we don't only mention the deficits, but we make sure that we mention the strengths that are also, coming about as far, from the evaluations, right? The other thing is that, parents, when they do not do this diagnostic test, sometimes they feel that something is missing. They don't really have, all the information, which is not always true. However, what I find as a psychologist who's been working in this field for so many years, I find in fact that in the field of psychology and special education needs, there's more of a leaning towards functional assessment. And sometimes there might be 2 or 3 different people from the same field who might have 3 different opinions. And therefore, I find that if I am taking a diagnosis via a diagnostic approach, and then also using the functional assessment, really gives me the best. Okay, some of the positive emotions that we have noted, in the data that we've collected, is that families are relieved, they feel very relaxed, they're very clear and confident, they're very optimistic and hopeful, right?
You have half a minute.
Oh, okay. So can we just go to the next slide then?
You will have to move them. You're moving them. I can't move
Oh,
them.
sorry. Okay. For professionals, what we find is that more with a psychodiagnostic approach, the positive emotions are they feel very decisive, focused in the kind of therapy that they will provide, but sometimes there's also frustration, agitation because of things like the cost, the lost time during interventions. Some of the things for functional, some of the emotions and behaviors following functional assessments is families get empowered, they feel more confident, independent, but there is also exhaustion, there is fatigue, they're embarrassed by what may be the findings. Similarly for the professionals, if things are not going the way they should and they do not have a diagnosis, then it becomes quite difficult to plan therapies. Thus, finally, I think if we are able to use both the approaches, it gives a very objective viewpoint as well as is keeping us in touch with what are the dynamic needs of the individual, both behaviorally and academically. I strongly recommend and do myself use a biopsychosocial model of mental health. And there are of course challenges, opportunities, but I think the biggest opportunity and benefit is family empowerment and community engagement. And I think that's really what we have to do, focus on dialogue and conversation, which has to begin at home and which will then flow into the community spaces, right? Thank you so much, Asha.
Thank you, Smita. Thank you so much. Can you stop sharing, Smita?
Yeah.
Last, we have a young girl called Darshana who wants to give her idea. Darshana, are you there?
Oh, yes.
Go ahead and speak, my girl.
Okay. Should I start?
Yes, please, Darshana.
Yes. Oh, hello everyone. I'm Darshana, and I'm 20 years old, and I'm currently studying in the last year of degree in Bachelor's of Economics. I'm also fashion blogger on Instagram and a YouTuber, and today I'm going to speak a little about my journey through cerebral palsy and how I have grown through it. So in 2001, I visited Ummi Development Center when I was diagnosed by cerebral palsy. My parents decided to give me the therapy there, and there I received therapy for around 5 to 6 years, and then we stopped. But when in 2014, I guess, when I was in 10th standard, I realized that I have to begin therapy again um, because there were few things that I was really conscious about, and I wanted to, develop myself for the junior college. So I went back to Meet in 2014, I think, and there I wanted to improve some things like walking. I wanted to improve my walking quality. I wanted to, I wanted to apply makeup. I wanted to, increase my speed. So there, my journey started with my therapist, where we both practiced goal setting. Now, goal setting is the thing where we used to set a goal that in 3 months or 6 months, we have to do this in a very perfection way, like I wanted. And so we used to set a goal that okay, in 6 months I have to apply kajal, or in 3 months I have to climb stairs. In
Darshana, are you there? Darshana?
Do you hear me?
Yeah. Darshana, we need to be a little faster. We need to stop in a half minute. Okay, please.
Okay. Like that, we have done. We have set the goals, and here I am. We still have lots of goals, and we try to complete them as soon as possible. So yeah, that's my journey, and thank you so much for having me here. Yeah.
Fantastic, Darshana. We are so very proud of you. So very proud of you.
Thank you.
It makes us so happy to see you like this. So as we come down to the end of the session, I have a pleasant duty to do. There is a QR code that is by the IACD. Please take that and do the survey, which is very, very required. At the last, you cannot finish a meeting without vote of thanks. I request our treasurer, Dr. Madhuri, please come ahead and give the vote of thanks, propose the vote of thanks.
Can you hear me, Asha?
Yeah, we can hear you. Go ahead.
Hello, everybody. On behalf of Indian Academy of Cerebral Palsy, I would like to express my sincere gratitude towards IAACD for making us a part of this global event. Thank you to all the participants who joined us today. A big thank you to all the esteemed panelists too for sharing their expert views. Also, we would like to thank the Society of Indian Physiotherapists for providing us with this virtual platform today. Thank you very much. Please do not forget to fill the survey, your feedback. Thanks a lot.
Thank you, Madhuri. Thank you so much. What do you, Mallikarjun?
I thank on behalf of Indian Academy of Cerebral Palsy, I thank all the panelists for sparing their valuable time disseminating their expertise and experience. And I received many messages from IASCD faculty who joined the meeting that they felt that this is an excellent session. And thank you once again. And I request all of you to join IACP to take our mission forward. In future, we will be having many programs with you. I hope you will support us in all our academic programs. Thank you, Asha, for moderating this session and it wonderfully. And this is an excellent session. I really appreciate you for taking a lot of pains in organizing this global listening session on behalf of IACP. Thank you one and all for joining the session. And we have one more webinar on RPWD Act and schemes of government schemes for persons with disabilities online. I request to all of you to join that program also. And we have a Mission Watchwords project. I request all the panelists to actively participate in our Mission Watchword project. For that, we may be writing to you in future to send an invitation to join our mission project, and kindly give your consent and give your expertise to take our mission forward. Thank you very much.